And then there's the third appointment, which is when you come back for a confirmatory ultrasound after you've taken the medicine, and that visit is a $30 visit. And if you need any kind of birth control, we can certainly help you out at that appointment as well.
We bring you to a clinic in North Carolina.
Okay, I'm glad you called back. I'll put you right back into the schedule for around 12:15 on Halloween Day.
An abortion clinic.
Okay.
We want to introduce you to Sally. She's the first person you interact with when you need an appointment here.
Well, my title is still, I guess, nurse coordinator for the clinic, but I primarily am doing triage now. All the changes in abortion laws have made the need to have me primarily on the phone. I used to be able to do patient care, keep the clinic running, all of which was doable. Now, I can spend an entire 8 hours just on the phone helping women navigate all the rules and regulations and trying to coordinate care, especially if they're calling from out of state, so that they can meet the regulations and restrictions that North Carolina has imposed on them. And it's daunting for these women to try to understand. I mean, I hardly understand all the restrictions. I don't know how they can make sense out of it. So my job is to try to make sense out of it for them so that they can get here and have the abortion that they need.
Sally's sort of like air traffic control for our clinic. She manages people's schedules, what they need medically. She answers questions. She understands how to get people where they need to go and how to care for them in the way that they need.
I can tell the minute I say hello, and a woman will say, I'd like to make an appointment. And I'll say, oh, okay, so what kind of appointment are you looking for? And there will be this complete pause. And then she'll kind of squeamishly say, I'd like to make an appointment for an abortion. So right off the bat, you can tell that she's either feeling ashamed or embarrassed or uncomfortable with her call. So once I say, okay, that's great, we can help you. So one of the first things I want to know is how far along she is. Then one of the first things I do is find out about their financial situation, because it can very often be a decision maker for women. And so phone calls can take a good 20 minutes, sometimes more, especially if they have a lot of angst or if they've just found out that very day that they have, a serious life-limiting anomaly in this very loved and desired pregnancy. Often they're on the phone crying. So phone calls are often very challenging and can take a lot of time.
After recent laws restricting abortion access here, Sally now has to take up even more time as an air traffic controller for our clinic. She spends her time reading documents to patients, which used to be over the phone, but now has to happen in person. We're not going to read the whole thing to you, but here's a taste of what she has to read. Who's paging you?
DRH perioperative nurse practitioner.
For one of your cases?
For one of my cases.
All right. Do you want me to pause or?
Why don't I step out?
Okay. I'll try to record this again, and then I'll read I'll read the counseling.
Okay.
All right, this is Bev re-recording the North Carolina state-mandated counseling that must be read to all patients 72 hours before they have abortion care. And just to put this into context, there's no other medical procedure where you have to read something mandated from the state that takes language from legislators and forces patients to hear it or forces a healthcare provider to read it. And so I'm going to read part of the surgical abortion consent form and acknowledgement of risk statement that is required by the state so that you get sort of a flavor of what patients have to hear. I won't read the whole thing. It's 4 pages long. And for patients who are potentially undecided if they want medication or surgical abortion, they have to have both sets of consents read to them because it's not one consent, it's 2 separate consents, one for medication, one for procedural. And so that's 8 pages of content that has to be read, and then it has to be initialed on every single line, which comes across as fairly patronizing for patients. By initialing each of the items below, I certify that I have received the following information about my care. The physician that will perform the procedure is, name of physician. If the specific physician is not known at the time of this consent or changes after the consent, the name will be noted below. She or he will be physically present during the entire procedure. If applicable, I've been given the name and phone number of the physician or physician team who will take care of me in the event of complications associated. I may view the fetus or fetuses by ultrasound and or listen to fetal heart tones if present prior to the procedure. I understand that printed information is available to me. I understand alternatives to abortion include carrying the pregnancy to term and either keeping the infant or infants myself or placing them up for adoption. I understand a surgical abortion is intended to end my pregnancy. I understand public assistance benefits may or may not be available to me under federal and state. I understand if I choose to carry the pregnancy to term, the father of this pregnancy may be legally obligated to assist in support of the child or children, even if the father has offered to pay for the abortion. I was told that the decision to undergo a surgical abortion is completely up to me. I was told that I could withdraw my consent for an abortion at any time prior to or during the procedure. I understand that I have a private right of action to sue the qualified physician performing the abortion if I feel I've been coerced or misled. And then in bold it states, I understand that I will undergo a surgical abortion. The discomforts, risks, benefits, and alternatives of the procedure have been explained to me. All my questions, foregoing initials and signature, and my signature below, confirm that I have voluntarily acknowledged and consented to each specific item listed above. And then there's a place for them to sign and date. And there's a place to sign that the patient has received this information in person. And that was reading it pretty quickly. And I will note that this does not include the relevant and important information that patients want about the procedure, what it entails, what the recovery is like, what medications they can take. Those are the important medical things that we convey to patients. And patients have the autonomy to make decisions in their best interest on their own.
It's a lot. So Bev.
I'm Bev.
And I, Jonas, are both abortion providers, or at least we remain so at the time of this recording, because unless you're living under a rock, you know that our right to do our jobs is currently being outlawed, especially around these parts. We'll talk a lot about the law, the Dobbs decision as we go along here. But first, what we've realized is that you may not know what abortion really is, who gets them, why they're medically necessary, why we shouldn't, as doctors, have to fear prison if we take our Hippocratic Oath seriously. So we decided to make this show for you.
If you listen to even one episode, we promise you will be the most informed person on the subject at your dining room table, which sadly has become a very popular place to discuss abortion right now.
This is your idea.
It was, well, we can both take responsibility for this, right?
Sure.
You thought of the name.
I did.
I'll give you credit for that. It was a good name. I mean, so many people have been frustrated with their inability to have a conversation about this with family, friends that don't agree with them. Actually, someone sent me a text yesterday. Let me share this text. And they said to me, you know, I moved to this very restrictive place. They were living in North Carolina, now living and working in a state that's very restrictive. And they said, I'm wishing I could have a long conversation with you about this. It's my first time ever living in a place where my neighbors are true Trump supporters and very pro-life. But these are neighbors I've come to love, whose children play with my children, and who I meet each month for book clubs, and we love our neighborhood. But I've had conversations about abortion, and even I find it difficult to defend my pro-choice beliefs sometimes. They bring up killing a baby right before it's born a lot, and it kind of feels so simple in their minds, like killing a baby, where it's, in reality, this care is complex and hard for parents and even the provider. And so I was like, well, in fact, we will have this podcast that you can listen to and think about how to have these conversations with people in a productive way. Based on some science, based on, you know, storytelling, the things that we've come to know and love.
That's a tough place to start a conversation if the people that you're talking with are talking about killing babies after birth, right? So they're propagating one of the major myths
Right.
that the anti-abortion groups use to try to, get support for anti-abortion stances.
Yeah. So where would you start? You're at the school pickup line and someone's like, God, I can't believe you do this work. Like, how can you sleep at night killing babies?
Yeah, I think I'd say, tell me more about that, or what do you mean by that? I mean, in any of these conversations, I think we probably have more in common than we have that divides us.
Yeah.
And so, from the text you just read, that person already has a lot of commonalities, right? And has similar values. And I think if you can take it back to a values-based conversation, then you can talk about why your values would be to support abortion in some circumstances and articulate that. And I agree, you shouldn't kill babies. So you guys already are in agreement, right? You're starting in the right place.
Yeah.
But we also know from the literature that leaning in and just arguing with people probably isn't going to get them to change their mind, that they're going to be more likely to change their mind if they come to it themselves.
Yeah.
And those are really hard conversations to have.
Yeah. But I think if you're a medical professional or if you're someone who really cares deeply about this issue, being quiet is not the option either. And so like finding a way for yourself to navigate those conversations.
Yeah. I also hope that this will help people who support abortion, right? And it's not about talking to people who are in greatest opposition to you. So when you're coming from that place of commonality, you just have to be emboldened to sort of have that conversation.
Yeah. And to not feel shaky when you're like talking about to know some truth.
Yeah. So we can share some truth.
We can be the source of truth. All right. This is our first session of recording topics. Defining abortion.
All right, Bev. Well, what is abortion?
What is abortion? Well, we can talk about what abortion is and what abortion's not.
Okay.
Because a lot of people have ideas about what abortion is, but it's fake news. So abortion is ending an established pregnancy in the uterus, I think. What do you think?
Yeah. Yeah, I think it's ending an established pregnancy in the uterus. I do think that that's broader than, right? I mean, it's good broad, but in the lexicon is different than what we describe abortion as.
Yeah. And so it encompasses other care that's not necessarily contentious abortion. Maybe there's contentious abortion, and then there's like what OBGYNs talk about as like missed abortions or incomplete abortions, and so it would encompass that as well.
Yeah. Well, you provided the medical definition. Okay, so can you provide the medical definition of a missed abortion?
A missed abortion is a pregnancy that stopped developing in the uterus, and there's no bleeding, there's no other signs of miscarriage, and it's often diagnosed when people come in for just their routine care and they receive the news that the pregnancy is not developing.
But a spontaneous abortion is really when the pregnancy passes on its own. So when the person carrying the pregnancy starts having cramping and bleeding and has passed the pregnancy out of the uterus, that's what I would call a spontaneous abortion.
And if you were, so let's say you're the doctor covering consultations for the emergency room and someone were to come in with a spontaneous abortion, could you distinguish that from someone who is needing care for a medication abortion?
No. Right. And that's the really hard part, is that so much of the care that we provide is overlapping. And so patients now who are presenting after having had a medication abortion may have a pregnancy in the uterus. You could be able to see an embryo and it might not have cardiac motion. And that would be really hard to tell.
Right. And so all of these cases that are criminalized of people coming in with either a spontaneous abortion or, what we would consider a miscarriage. Like there are people who question the circumstances around that, or if the person was like doing something that caused it, whether it be taking medications or taking illegal drugs or, whatever it might be. And so those cases can become criminalized when it's just like a normal thing that can happen to a developing pregnancy.
Yeah. Yeah. And then, I mean, we haven't covered all of the euphemisms for abortion. I mean, I think most often when people talk about abortion, what they're describing is an abortion where someone took medications or had a procedure to remove a developing pregnancy from the uterus. And that's the circumstance that we're most often referring to and is the most restricted. But because of the way laws are written, oftentimes the language is broad enough that it may make it difficult to provide that other care. And because, as you pointed out, the clinical circumstances may look the same for someone who's having an induced abortion for which they took pills as someone who's having a missed abortion for which they haven't taken anything.
Right. And those patients who are judged or miscared for, that happens by the medical community. Like, it's medical providers, it's nurses, it's doctors, it's people who are supposed to be part of the system of care that become the system of judgment.
Yeah. And so sometimes people aren't able to get care because doctors are so scared that they're accidentally going to end a pregnancy and provide an abortion if that's against the law, even if that care is the right thing for the patient and is potentially life-saving for the patient, right? If the patient's bleeding and is at risk of more bleeding, but they can't say for sure that the miscarriage already occurred, then they may not, they may be hesitant to go on and provide care in that circumstance.
Right. And if you live in a state where the penalty is a $100,000 fine, loss of license, and up to 99 years in jail, you're going to have to be really damn sure before you intervene. And so, and if you're in a small hospital where maybe you don't have all of these fancy pants lawyers around who are helping you understand the law, you feel like you're on your own, and that's a lot to lose.
So why do you think it matters to be in a small hospital? I mean, what's the difference?
I mean, those people are out there caring for rural communities in a way that they need, in a way that's really important. I mean, if you're multiple hours away from a major hospital where you may have all the subspecialists, you need to have a really good system of care in your community to provide care at the front lines. And, 20% of up to at least 20% of people experience miscarriages with pregnancy. And so that's a common thing that happens. That's a common thing that emergency room doctors see. And, they have to be willing to care for that patient population and not hesitant, because rarely those patients can bleed to death. They can have severe infections and die. And if you're hesitant in intervening, lives are at stake. I mean, we've seen these cases, right? These are the ones in the news that get popularized. And most of the time people don't bleed to death, but they lose enough blood that they need a blood transfusion. And those are interventions that are not necessarily without risk.
Yeah. So what should happen when someone comes in with a miscarriage?
Ideally, they can talk to someone who knows the options of care. And some patients don't want to intervene. We care for patients all the time that want to let nature take its course, and that's fine. If that's their choice, I think that's fine. There are some patients that want to intervene as soon as they know that there is a miscarriage. And the thought of walking around with a pregnancy that's not going to continue, it's just that's just unfathomable for people.
So let's back it up a minute. So we started off with defining abortion, right? And then we
digressed.
We digressed and took ourselves on a tangent. But we started off with defining abortion. And so
I think what unites these patients are that they're all capable of pregnancy. They have a uterus and they have a pregnancy in it and have different hopes and dreams and wishes for where they want to go with that, where they want to go with their life.
Mm-hmm. And it sounds theoretical that someone could come into the emergency department and look some way and be difficult to interpret. But I would say every time I'm on call, there is a pregnancy. There's a person who presents with a pregnancy and they are having a miscarriage or might be having a miscarriage. And we as a medical team need to help them figure out what's going on and help them figure out what to do. And I feel fortunate to work in a setting where we are able to often be doctors and rely on evidence and rely on medical information. But you were talking about small hospitals and rural hospitals where I think it's hard to interpret the law, to understand the 43, 47 page laws on abortion. And so you're worried about running afoul of those laws. And so then what do? Well, you send someone to a center where they do have help from attorneys and experience with that clinical scenario. But the fundamental care that you're providing, I mean, they know how to provide it as well as we do, right? If they've been trained in OBGYN, then they know how to care for a first trimester miscarriage.
You know, what happens is that people in these small hospitals over time are faced with these scenarios where they can't provide evidence-based care because they don't have the support or they're scared of the law, and they end up moving. And so then you have no OBGYN in this rural hospital, and you end up with scenarios that we encounter where someone has an ectopic pregnancy that ruptures and there's no OBGYN in the hospital to care for them. And so they have to emergently send them where we can care for them immediately, but it puts that person's life in grave danger when this is just like bread and butter OBGYN. Like, this is what we are trained to do, we're capable of doing, but people are unwilling to live in those small places where they don't have the support.
So how does pregnancy happen? How are babies made, Bev?
Well, when there's true love. No. So an egg and sperm have to unite, and the egg is released during ovulation, and the sperm unites with the egg, forms the embryo. The embryo makes its journey through the fallopian tube, implants in the uterus, and when the embryo implants in the uterus, that's when the pregnancy starts.
So it's a zygote at that point, though, right?
Yes.
So
it's already dividing cells, but once it's implanted and is an established pregnancy, that's pregnancy.
Right. So the important definition here is that pregnancy begins when a fertilized egg implants in the uterus.
Yes.
And so I hear misinformation about that a lot, and often groups that are anti-abortion are trying to define pregnancy as that moment where sperm and egg meet. And that's not consistent with the scientific definition of pregnancy. It's not consistent with the definition of pregnancy that we learn as obstetricians and gynecologists, or that doctors learn in medical school, right?
Right.
Particularly when half of those fertilized eggs are not going to implant, right? And so if you're equating abortion with not getting pregnant after there's a fertilized egg, then first of all, there's a lot of people having abortions every day. But secondly, it's not consistent with the science. I don't know.
Yeah.
So what's an ectopic pregnancy?
So ectopics they can implant in the fallopian tube most commonly, where the fallopian tube connects to the uterus, which is called either cornual or interstitial ectopic pregnancy. And those are particularly dangerous because there's so much blood flow there. So if that ruptures, it can be catastrophic. They can implant in the C-section scar. And so with C-section rates going up, more and more patients are being diagnosed with C-section scar ectopics, and those are also particularly dangerous. And then it can implant in the cervix very rarely, or it can implant in the belly, like on the bowel or
Liver,
or, some other, the ovary or some other area that, again, those are very, very dangerous pregnancies.
So, I mean, as providers at a tertiary care center, we get referrals for all sorts of things. But when you mention that ectopic pregnancy is bread and butter, right? I mean, oftentimes it's a pretty clear diagnosis that someone has a pregnancy outside the uterus and they may be bleeding. And if they're bleeding, then they need surgery, and they need surgery emergently. And so I think our classic teaching is that you would never transfer a patient in that situation. But since Dobbs, we've seen several patients transferred to our institution because they didn't have clinicians who were expert in providing that care there's no longer an OBGYN there or another surgeon who's comfortable providing that care. I think in other settings, we've talked to colleagues in Tennessee who their law was so vague that they thought that they might be charged with a crime if they treated an ectopic pregnancy because there was an embryo and that embryo maybe had cardiac activity, or it could develop cardiac activity, and the law there didn't specify that the pregnancy had to be inside the uterus. It could be defined as, well, that's not consistent with our definition of pregnancy, but it was consistent with their law, right?
Yeah, right. And, and this is how these laws encroach on so many parts of reproductive health care, whether it be contraception, IVF, ectopic pregnancy management, miscarriage management. It's a spectrum of care that we offer it's all interrelated.
Opinions expressed on this podcast are our own. Philanthropy is helping us highlight these stories, and we hope you'll continue supporting this work by subscribing and sharing the show and getting involved in your local community. This podcast is executive produced by us, Dr. Beverly Gray, Dr. Jonas Swartz, and Jane Marie. Production by Little Everywhere. Thanks to Nick Thornburn and Patrick Ford for our score, and Jamal Walton for original artwork. Extra special thanks to everyone who lent their knowledge and voices to the show.